Hello, my name is Merron Simpson and I'm Chief Executive of the Health Creation Alliance. And we're the leading national cross-sector movement addressing health inequalities through health creation. And I'm going to introduce you to my colleague, Chris Tiley.
Hello, yes, I'm Chris. I work in Truro PCN and Merron's been enlightening me for the last 4 or 5 years about health creation. So it's good to catch up.
Thank you, Chris, and it's lovely to see you again. And I'm looking forward to hearing more about the work that you've been doing in Truro to shift your general practice and your PCN to a more health creating model. I think 18 months ago, after many conversations, we worked together to generate a set of 9 steps that PCNs might take towards this goal. And you participated in an online event hosted by the Health Creation Alliance in September 2020. It was one of 3 events that was supported by NHS England and NHS Improvement, looking at how PCNs might work with communities and other local partners to address health inequalities. And you also came to an event about 3 weeks later that we ran, a lunchtime session, where there were about 30 participants and many GPs among them, helping you to refine this stepped process. So it's so good to have the opportunity today to just do a little bit of a review, just to check in with you, to see how it's going, how much you've managed to do from these 9 steps. And maybe from this exercise, we might be able to start to improve those 9 steps, to do a bit of reshaping and develop an even better toolkit for others. So I'm going to just hand over to you to say a few things. I think the first point that you made in your toolkit is that actually a change of heart is needed by PCNs. And for this approach to be lasting, health creating approach, it needs to be, the locus of control needs to be within the community rather than driven externally or by the PCN.
Yes, yeah, that's right. I mean, it's the kind of first point on the list and probably the most important. I think normally when you give an organisation responsibility to do something, it's very natural to want to hold on to that responsibility. But PCNs are by their nature quite kind of inward looking and good at managing clinical issues and managerial questions. But when it comes to health inequalities and health creation, it's so crucial that the locus of control, the actual control over how things are improved and services are reshaped, is with the community and not with the PCN. And that mental shift to allow that responsibility to diffuse into the community has, it's happening, I think, a little bit slowly, but it's getting there. I think health inequalities is now kind of PCN essential, as I'm sure you're aware. So the PCNs have to confront it and work with it. So it's how you make that system work. And, I think that what we've come up with, working through a third sector organisation called Chaos to reach families in difficulty, has been a really important step in disengaging the PCN from their primary role in trying to control everything. So we've succeeded in the sense that a lot of the work in the community is not being done directly by the PCN, so that's been uncoupled, but that mental connection with still wanting to be in control of it, I think, is still lingering on. And I think proof of concept, as the project works and we can show that trust is justified, will hopefully help that kind of letting go to continue, if that makes sense.
It does. You mentioned an organisation called Chaos.
Yeah. Yes.
And just say a little bit more, because I think this is probably linked to one of your other points, which is about having a community DJ or maybe a member of the community or on your PCN executive.
Yes, correct. I mean, Chaos stands for Community Helping All of Society, and it's a third sector organisation that's been running in Truro for a few years, and they have various different briefs, but they're very well connected in lots of levels of the community. I know one of their key workers called Katie Hutchinson, and through conversation with her, we were discussing how can we come up with a project that's really going to create better health And a recurring theme has always been early intervention to try and help young children get on the right path before they get into problems that can never really be reversed, to help their parents in that process as well. So Chaos, through their contacts in the community, isolated another group called Wild, who work directly with kind of troubled families or parents who may be in danger of losing their children to social services. And this is exactly the kind of group with multiple problems who are marginalized and not very good at accessing healthcare and services. This is the group where the potential health gains and health creation can be greatest. And that link with Chaos, with Katie and her colleague Laura, being a bridge really between the PCN and other community groups that they know about but we don't, and beyond that the individuals themselves, is the network we're trying to develop, with our project's goal being to improve school readiness just as one metric, but the process of connecting is probably the most important part of that.
Okay, thank you. So during those events that we ran in 2020, it became apparent to us, and we wrote it in our reports, that we needed a particular role to help to connect the PCN with the community. And we called it a community DJ, but we also called it a strategic relationship development lead. And I think what you're saying, am I right in thinking that actually in your part of the world, that role is being carried out by a member of the community? So it doesn't actually perhaps need to be someone who's employed by the PCN, although presumably you could be employing someone who reaches out in that way.
Yes, I mean, I suppose ideally, I mean, Chaos is a kind of third sector group. Katie is she works within Chaos, so she's a community member without being a kind of independent community member. But the movement would be towards, devolving that role, hopefully, to people in the community who want to take that on. So I think it's kind of a work in progress, but I would imagine a future community DJ as being somebody who bubbles up through the process of engagement, who is charismatic and has got energy and has got community connections, and who can maybe work alongside Chaos to begin with in the PCN, but then maybe have more of an independent role, but someone who can interface and enable. That would be a good future development.
Lovely, thank you very much. You put that very well. And a number of the other steps on your 9 steps was around having a designated Health Inequalities Lead. That's me. Lead clinician, I should say. That's you, is it? Okay.
Yeah, I've managed to wangle my way onto the PCN Executive, so I'm now there every month on the PCN Exec, thumping the tub for health creation, and trying to introduce different relevant people from the community or community services to the PCN. So we develop this kind of more inclusive mindset that there are lots of other people out there who are part of the bigger picture. So we've had people from the council, and we've had someone from public health, we've had someone from Wild that I mentioned. I'm planning to get someone along from housing, policing to come as well. So just broadening the kind of cast of people that the PCN are working with, and getting used to that idea that there's a kind of much larger pool. We're calling it the PCN Big Tent. It's our kind of catchphrase. So we're just trying to work out all the different people who might be in the room to contribute. And in fact, next May, I'm trying to do a takeover of the PCN Executive with a wider group of these people, so we can look at our PCN aims for the next year. What do we want them to be? So it'll be less of a clinical business meeting and more of a kind of where do we want to go with our community planning.
Okay, so I think you said to me that you haven't yet got a member of the community on your PCN Executive, but that you're building this big tent nevertheless with all these partners. Now, how do you see that going in the medium term? Do you think you need at least one community member on your executive, or not?
Well, I like, in theory, it would be nice to have somebody there. I mean, a lot of the PCN Executive meetings, there's a lot of territory to cover, which is not normally very exciting. But what I've done is to have a kind of standing item about health creation at the start of the meeting. And I guess if we could have a community member being part of that bit of the meeting, Not that I want to exclude them from the rest of the PCN executive meeting, and they might want to stay for reasons of transparency or trying to understand it. But it might be more realistic to have a community member coming for the community bit of the PCN meeting and then signing off. But that's something we haven't quite worked out yet.
Okay, thank you. And one of your steps here is around quite specific. It's about a specific role for financial advice because of the number of people that come with problems with benefits and debt and poverty. And I just wondered if you were any closer to establishing that person within your practice or within the PCN.
Well, we do have a social prescriber, one of whose briefs is to advise on financial problems. So in a kind of roundabout way, yes, we can refer people to a social prescriber who can then sit down with them and talk about those things. Understandably, people aren't always forthcoming about financial problems. They can find it socially embarrassing or not be sure how to broach it. So I think rather than coming to the surgery or seeing an official social prescriber, it would be good to develop that role in a way that was more embedded so that people could come along and ask for help. And there's something really important about having trusted contacts, especially if people are marginalized. So hopefully through this kind of slightly contact at second hand through chaos or chaos via wild, people are going to be able to be more comfortable to mention those kind of problems. And that can then be fed up the line back to us if necessary to see how else we can help. But I think there's a lot of trust building that's still going on, the fruit of which hopefully we'll see later. Yeah,
thank you. And I think you've covered the point about outreach. You use the example of the Cornwall Farmers Club in your steps, but that could be lots of different things in different places. I did wonder. Then number 8 on the steps was looking to see if there's an anchor institution that could help with that and local resources, whether it's a council or a hospital or whatever. And is that something that you've managed to do or that you still think is important?
Yeah, no, I'm glad you asked me that one. I was actually speaking to the mayor of Truro a couple of weeks ago. I had a meeting with him and a few other people about social prescribing. Now, luckily, the mayor, called Steve Webb, has made it his priority for his mayorship to develop good social prescribing in and around Truro. So we're all over that, and we're trying to link with the mayor and the Truro Town Council, not only to improve social prescribing at the health park, but also to expand the availability of social prescribing around Truro. We're looking at developing a QR code that people can just scan on their phone to give them up-to-date information about what's available to support people's health and well-being around the city. And he's very keen to engage in any way he can to help develop those kind of services. So yeah, I think it looks like our anchor institution is looking more like the council and the hospital. I think they've got lots of other clinical workload issues at the moment, and I think the council's door is very much open for further discussion.
It does sound really exciting. It sounds like you're really generating a movement there, looking for where the energy is, finding the people who want to be part of it, and things are spreading, and movements are a spread mechanism. So I don't know if you want to just, as we come towards the end of this, say more about what you'd like to do next and how that spread might work, and how you're working with other PCNs.
Yeah, well, sure. I mean, there are a few other PCNs that are working on similar projects around Cornwall. And next month, I'm a GP trainer, and I'm going to be just giving a talk about where we're at with our project, but also I've invited the other projects to send me a few slides so I can update the whole trainer community on where we are with health creation. And hopefully through mechanisms like that, that's the kind of spread you're talking about. If that gets out to other PCNs from an educational point of view, I hope that'll be useful. Within the Truro PCN, I think it's all about firming up this kind of network that reaches out. I mean, from the PCN via the community DJ or chaos to their second degree kind of contacts like Wild, and from there out to the individual families and people. And maybe a kind of specific younger person as well could link up and be a bridge to a younger population who often get forgotten, I think, in these discussions, or potentially. So I think at the moment it's all about developing the network whilst carrying on trying to soften up the kind of PCN mentality to just kind of trust that we don't have to hold all the cards. And I'm really hoping that, having kind of delegated to Chaos and Wild, that when the information is all coming back, as it's starting to, people can see that there is a kind of result that they can buy into and build on. So results are always going to be interesting when they come back, but I hope that the exercise in itself will be helpful, but also that from a measurement point of view, there'll be something there that we can take back to the PCN and say, look, this is actually really interesting data that we've got, and these are the improvements that might follow. So there's various different answers to your question, I guess.
Excellent, thank you, Chris. So like I say, it's been great to catch up with you, great to hear about some of the work you're doing. It's actually moved quite a way since we started this work 18 months ago. And the Health Creation Alliance works in this way with its members to help to spread, support, share learning, etc. We're available to do that kind of thing, run those networks, movement, and enable all of that. And I'm so pleased to hear that things are shifting for you and moving on.
Yeah.
So I'll catch up with you later, and we'll start to reshape this toolkit, and then we'll try and make it available for others to learn from as well. So thanks, Chris, for your time now.
Thank you, Merron.
Bye-bye.
Bye.